Thank you. Good morning, everybody. Welcome to another session of the Fellows Academic Rounds. Today we have three recent publications from our Posi senior faculties, and we have three papers. The first is defining and differentiating congenital vertical talus and congenital oblique talus. We have Dr. Dhiren Ganjwala, sir, speaking on that. And then the second one is, does prophylactic pinning affect the proximal femoral femur morphology in slipped capital femoral epiphysis? And we have Venkat sir to discuss that paper. And the third one is from the International Posi Study Group. It's on predictors of persistent limb following proximal femur varus osteotomy in Posi. And we have Hitesh sir to discuss that paper with us. I'll ask Dhiren sir to share the screen and we can start.
Yeah, can you see the screen?
Yes, sir.
Okay.
Yes, sir.
Good. Good morning, and it's a proud privilege for me to speak on this recent study which we published in Journal of Bone and Joint Surgery. I am speaking on behalf of our team, that's Professor Vincent Mosca and Dr. Hitesh Shah. Three of us carried out this study. So I will try to give you a very simple explanation about the concept. The reason is when we read the paper, it's very difficult for everyone to understand the thing. So just a minute. Yeah. So this will be a very simple explanation. If you want the read this article, it's open access article, so anyone can access that from the Journal of Bone and Joint Surgery website. So first of all, why we carried out a study? To give you a background, Professor Mosca, Hitesh, and I were discussing about the non-operative treatment of vertical talus. And in that, we said that in some of the papers, the results are good, while on the other end, in some of the papers, the results are not good with the non-operative treatment. That's a reverse Ponseti technique. Then we came to conclusion, not conclusion, but like the possibility that it could be the different population, that the study with a good result has a milder case, while the study with a poor result has a more severe vertical talus. And that's the reason we are not able to compare, or like say one study has a better result while the other has no. So then we thought about that when we look at the vertical talus, it's a spectrum. On the left, we have a normal foot. Then on the right, we have a classical vertical talus. In between, we have a flat foot and an oblique talus. Now, the sad part is that, Sandeep, can you please stop your microphone? Yeah, so it's a spectrum, and in that, we have flat foot and oblique talus in between. Now, the major important point is that we really don't have a demarcation line where the normal foot becomes a flat foot, where the flat foot becomes an oblique talus, and where the oblique talus converts into vertical talus. So in this study, we try to define these criteria so that the future studies can use this criteria to analyze their result, and that will probably help us. At the end of the my talk, I will give you idea about like how this paper is going to help. So let's start with the basic understanding. When we talk of vertical talus, there are two components of the deformity. The first is there is an equinus at ankle, and that's because of the short tendo Achilles and maybe because of the capsular contracture of the posterior ankle and subtalar joint. So as shown in this, the talus is in a plantar flex position. That's a hindfoot deformity. The second component, which is very important component, is that there is a talonavicular joint angulation as well as translation in this condition. So again, shown over here, the talus is plantar flex, but the navicular is dorsally displaced, and also the axis of the first metatarsal is making an angle with that of talus. So there is a talonavicular joint angulation as well as translation. So these are the two components. So the aim was to study the relation between whether the severity of ankle equinus and the talonavicular joint deformity, whether they go hand in hand or they are two different components. And we really need to look at those two components. Regarding the material and method, we analyze 71 feet. It's a retrospective study. So all the patients pre-treatment X-ray we analyze. And these patients, they presented to the clinic with a complaint of vertical talus or possibility of vertical talus. We obtain dorsiflexion and plantar flexion lateral views. And then we measured 3 parameters on each view. So we have total of 6 parameters. So then the next point is like how the lines were drawn. For the measurement of the angle, how we draw the line. So for the tibial axis, we created a template and we use that the long axis of the anterior surface of the or the anterior border of the talus and the midpoint of the width of the tibia, we draw a parallel line and that becomes a tibial axis. You can see on this that this is how we measure the tibial axis. For the talus axis, we know that the talus is not ossified completely at young age. So there is a small ossified portion and we draw a dorsal and the plantar surface and midpoint of that is taken as a talar axis, again shown in this figure. For first metatarsal axis, we again created a template which is almost like the tibial template. And again, the long line is kept parallel to the dorsum of the first metatarsal. And as shown in this figure, you can see that this is basically the line. So now we have tibia, talus, and first metatarsal axis. Then we measure the angle. The first angle which we measure is tibiotalar angle. So the angle between the long axis of tibia and the talus, that is the angle, that's a tibiotalar angle. And that angle gives us idea about the equinus component of the deformity. If angle is more, then it suggests that the posterior structures are short and there is a more talus is more plantar flex in relation with the tibia. The second angle which we measured is the talo first metatarsal angle. So it is something like this. The long axis of talus and the long axis of the first metatarsal, and we measured the angle as shown in blue. So this is the second angle which we measured. And then we decided where these two lines, the line representing talus and the line representing the first metatarsal, where they intersect. So that's, we call it a chora. And for that, we divided the talus into various components. So this is an important point I would like to explain how we evolved this concept. So we divided the long length of the ossified portion into 3 portions. So with the help of 2 lines, we divided into 3 parts. Then we extend the another line on the posterior aspect of the long axis. So that's another line. The 1/3 of the length of the talus, ossified portion of the talus, is drawn as a 4th line. And then we divided the part of the, if the chora is on the anterior aspect, we call it zone 1. If it is in the anterior 1/3 of the ossified portion, it's zone 2. The middle part is zone 3. This is zone 4. This is zone 5. And the rest of the posterior part is called zone 6. So that's where these 2 lines are intersecting. So in dorsiflexion stress view, we measure 3 angles: the tibiotalar angle, the talar first metatarsal angle, and the chora of talar axis and the first metatarsal. Later on during the study, we realized that the remaining, the last 2 are not important in dorsiflexion view. So we kept only studying the tibiotalar angle. We have measured all the 3, but later on, while preparing the manuscript, we realized that we really don't need to have the other 2. So we kept only the tibiotalar angle in dorsiflexion stress view. In plantar flexion stress view, again, we have similarly 3 components or the 3 measurements. And from that, we removed the first one, that's a tibiotalar angle. So we have only two remaining for the plantar flexion view. So if you combine these three, then we have analyzed three criteria for the rest of the study. So in dorsiflexion view, we measured the tibiotalar angle, and in plantar flexion view, we measured these two parameters. So just to give us an idea, so this is a dorsiflexion tibiotalar axis, which is 121. This is how we have measured it. This is again the angle, the talus and the first metatarsal axis, which is minus 23. And this is where the cora is, the two lines are meeting at zone 6. So now the question is there any association between the hindfoot deformity, that's the equinus, and the talonavicular joint deformity? So on the x-axis, we have a plantar flexion view talar first metatarsal angle. And on the y-axis, we have a dorsiflexion tibiotalar angle. We took this 2 point, the 0 and the minus 50 as a demarcating line. And on the y-axis, we have 105 and 150 angle as another demarcation line. So now we have 4 lines. So this divide into 9 components. If the hindfoot and the forefoot, that's a talonavicular deformity, are parallel, in that case, we would have something like that. We will come into that in a minute. So this is how we differentiate that when we call it oblique talus and when we call it vertical talus. And if there is a correlation, then we will have something like this. However, when we draw a graph, it comes to that it's not that it's only the 3 zone, but it's in the other 3 zone also. So this is the distribution, how this 71 patients, they came into this different zones. So we realized that it's not a one type of vertical talus, but in some type there is a less equinus also, or in some oblique talus there is a more tendoachilles contracture. So these are the various types of deformity. Coming to the next point, ankle equinus and talonavicular joint dorsiflexion angle, they don't go hand in hand. So that's the first important point which we concluded. Coming to the very important thing, say in practice, it's very difficult to measure all these angles. So then we realize that there is an easy way to differentiate the oblique talus and the vertical talus, and that is by where this cora of these two lines are. So as you know that these are the 6 zone. And then we realize that there is a linear correlation, almost linear correlation, where the cora is and the plantar flexion view, stress view, the talar first metatarsal angle. If that angle is more than 0, then all the cora were in the zone 1. If angle is between 0 to minus 50, that's a oblique talus, then all but 1 were in zone 6. And if it's a vertical talus, then some of them were in zone 4 or somewhere in zone 5. So if we plot this with this picture, it becomes very clear that if cora is in this zone, zone 1, it's a normal foot. If cora is in zone 6, it's a oblique talus. And if cora is in zone 4 and 5, it's a vertical talus. None of the patient have cora in zone 2 or 3. So just to give you the idea, this is the cora in zone 4. So it's a vertical talus. Here, the cora is in zone 6. So it's a oblique talus. And here, the cora is in zone 1. So it's a normal foot. So now the most important point, how this study will help. We all know that when it comes to comparing the two things, we cannot compare apple versus oranges. So the point is like oblique talus and vertical talus, they are different and we really need to differentiate them. So this will help in comparing the different studies. Let's say that there are 2 studies which we are discussing. Both have a patient's population of 25 feet. However, in study 1, the 13 patients are severe cases and the 12 are milder cases. Then we cannot compare it with study 2 where there are only 5 cases are having a severe deformity. Because if we compare them, then naturally it would be an inappropriate comparison. This will also help in prognostication. Before starting the treatment, that this will give us an idea whether the non-operative treatment is going to work or the child will require surgical treatment. And it may give us the idea that how many plasters will be required. If it's a milder deformity, then only with few plasters the deformity will be corrected. And if it's a real vertical talus, then probably plaster treatment may not work. So just to end my talk, if we want to study the animals in the cat category, then we really need to have our classical features to distinguish each of the animal in the same category. So the same thing is like this study will help us to differentiate oblique talus and the vertical talus. So that's what about the study, and I will be happy to answer your queries of that. Yes, any
Yes.
question?
So we have one question. Maulin sir has asked, does bony ossification represent the true center of talus, especially in
Okay.
infants?
Okay, that's a very, very, very important question. And still we don't know. And that's why we are trying to develop the next study to have MRI of the few patients at earlier age. And that will give us an idea whether the ossified portion axis is matching with the axis of talus.
Can I comment? This is
Yeah,
Vince
please. Yeah.
Hi, Dhiren. I thought that was a fantastic presentation of our work. And you and Hitesh and I spent a year trying to develop something that had not been developed in the history of medicine. And this is a significant finding because in 2024, before this study, there were no objective definitions of two common terms. Everyone talks about congenital vertical talus. People talk about congenital oblique talus. They write about them, but there are no definitions. So as you appropriately pointed out, how can you write about, how can you study something you cannot define? For those juniors here, you might be wondering why we measured the axis of the ossified talus and the axis of the ossified metatarsal when we were concerned about the talonavicular joint. And the answer is, again, you've presented so much information in a short period of time, but the answer is that the navicular does not develop ossification for 3 to 4 years. So the navicular and the medial cuneiform and the first metatarsal go every place together. There's no mobility between those 3 bones. And if we by drawing the line through the first metatarsal, we imply appropriately where the navicular is, and then that's our proxy for determining the relationship at the talonavicular joint that we really cannot see. So that's the first point. And the other important point is that the terms are congenital vertical talus and congenital oblique talus. The focus is on the talus. And what our study showed is that that doesn't matter. How vertical or how oblique, how rigid or supple the plantar flex talus is not what differentiates rocker bottom foot deformities. What differentiates them is how rigid or partly supple the talonavicular joint dislocation is. So really important point, our definition and differentiation of vertical talus and oblique talus without changing the terms is that it doesn't matter about the talus, it matters about the talonavicular joint. It would be impossible to eliminate those terms in the literature. So we're just saying you're going to have to believe us because our data was so clean, especially based on the foot Cora method, that these are 2 different conditions. They've been grouped together. The reported outcome studies are unreliable and not believable because we don't know what percentage were in each study, and that we need to keep the terms, but understand that although the terms have the word talus in them, The real thing that we need to appreciate is what's happening at the talonavicular joint. So again, Dhiren, I thought it was a fantastic presentation. I love your artwork, and I just want to add those comments.
Yeah, thank you. You really brought the point which I missed, that why we are measuring the first metatarsal, because we are not, or the navicular and the cuneiform, they are not ossified. So we are taking a surrogate marker as a first metatarsal. Yeah, I missed that point in my presentation.
No problem.
Thank you so much, sir. If there are any more questions in the chat, I think we can take it up later. So we'll move on to our second paper. Venkat, sir, you can share your screen.
Yeah, just give me a second. Share view is not showing. I think I'm not allowed to share it. Can you ask the host to? Yeah, now it has come. Yeah. Can you see my screen now?
Yes, sir.
Yes.
Good morning. It's very difficult to follow Dhiren, sir. I'll try to do my best. So this is a simple paper which we published in IJO a couple of months back. So this was basically a paper which we did to look at the morphology of the proximal femur, what happens after prophylactic pinning in slip capital femoral epiphysis. And this is the same paper which we got the best paper award in POSICON 2023. So we all know that contralateral slip is one of the avoidable complication in a patient with slip capital femoral epiphysis, and the incidence of contralateral slip is variable, reported in literature between 10 and 70%. But in general, we say that it is about 20% when we counsel the patients. When you see a patient with SCFE, we always say that there is a 20% chance of a contralateral slip, and we offer prophylactic fixation. And what is more important is these contralateral slips can be sometimes acute unstable, which is in the literature we know that unstable slips have more rates of avascular necrosis compared to stable slips. And the incidence, as we discussed already, there is variable reports, and this is an epidemiological study of a large number of patients, and they've studied that the chance is like 2,300 times more in a patient with slip. And it is published. I mean, there are the pendulum is swinging between pro-prophylactic pinning and not prophylactic pinning. Between there is various publications, and there are few papers which say that it is a easily avoidable but a potentially disastrous complication, and it is better to safely pin them rather than having a continuous observation, particularly when you know that your patients are not going to be in regular follow-up. So it also depends upon the kind of setup you work in. So this is a paper from Sweden, which again showed that 40 to 80% of them have an increased slip in. I mean, patients can have developing arthrosis if you miss a slip. So what are the advantages? Actually, it is a very low morbid procedure, prophylactic pinning. If you do it properly, the risk is very less, but it has got a high prophylactic benefit. Though there are reports of complications during a prophylactic pinning, it's very far and few. So if you learn to do the procedure properly and do it executed properly, I don't see any major risk in doing a prophylactic screw fixation. What are the advantages? It prevents future slip. So what are the disadvantages? If you look at it very carefully, it can stop the growth of the proximal femur, which will definitely alter the morphology. And it's an additional surgical procedure. Whatever said and done, it is an additional surgical procedure. And there are reports of avascular necrosis as well as chondrolysis. You know that when you operate on a normal hip and cause a complication, it is very bad. So you should be actually looking at the risk and benefit before doing this procedure. And now there is trend towards using growing implants to preserve the proximal femoral morphology. And if you look at the incidence of slip capital femoral epiphysis, over the years we see more and more younger patients, which means that if you stop the growth in a, say, like 10 or 12-year-old boy, so the chance of having a altered morphology is very high. So the world is moving towards growing implants. So our institution protocol is to offer prophylactic pinning for all patients with the open physis. We use a 6.5 fully threaded cancellous screw on a steady loosened table, and this technique was already published in the same journal some years back. And this paper, we wanted to look at what happens really to this prophylactic pinning, because we have been doing this over the years. And when we looked up the literature, there is very limited information where people have studied the morphological changes following prophylactic pinning. So in our database, over a period of 10 years, we had about 171 cases. All of them were scanned. And then we took up the patients only who had follow-up till skeletal maturity. So we had 58 hips. Those patients who less than 2 years follow-up and who are lost of follow-up were obviously excluded. And we wanted to measure the radiological, these following radiological parameters. So first is the length of the neck. So length of the neck, again, there is no defined way to measure it. This is what we use from the midpoint of the head of the femur and the point which is along the shaft, line drawn along the shaft of the femur. So this we measured as neck length. So this is the immediate post-operative picture, and this is the skeletal maturity. You can see that the neck length is increased in this patient. Next is the neck shaft angle. So we presume that when we put a screw across the proximal femoral epiphysis, the neck shaft angle decreases. So this is the next parameter which we wanted to measure. It's a standard way to measure the neck shaft angle. This is immediate post-op and at skeletal maturity. So we will look at the results in the subsequent slides. The third is the femoral offset, the lateral offset of the femoral head. Again, this also is a measure of what is happening to the proximal femoral growth in terms of growth. This is an interesting one because it's an articulotrochanteric distance, because we know that when we are fixing the proximal femur, there is a trochanteric apophysis which persistently keeps growing. And if you can see that this is the post-operative X-ray where the articulotrochanteric distance is about 3 millimeters, and you can see 3 centimeters, sorry. And in here at skeletal maturity, this distance is significantly decreased. And we know that from hip biomechanics that the tip of the trochanter should always correspond to the center of the head of the femur. So the decrease in articulotrochanter distance can potentially cause a Trendelenburg sign positive or a Trendelenburg gait. And next is tip apex distance, which is the distance from the articular surface to the tip of the screw. So these are all the radiological parameters which we measured. 2 different observers measured, and we did an intra-class correlation for inter-observer reliability, and student t-test was used to compare the means. The mean age in the paper was about 13.7 years, but there was a wide range. So the youngest was 9 years and the oldest was 16. We had more boys in the group, in our cohort, and the mean follow-up was 37.8 months. It is not years, the typographic error. So this is in our population, the mean follow-up was about 37.8 months. So this is the most important slide of results of various parameters. What happened in post-operatively, how much was it, and final follow-up, how much happened. So if you look at all these parameters, the neck length, there is increase, but there is no significant change according to statistics. But the neck shaft angle, so again, there is no significant change. There is significant change in these values: mean neck length, head neck offset, and if you look at the articulotrochanteric distance, this is the only value which has decreased. So initially it was 25.6. At final follow-up, it is 20.8. And again, tip apex distance is increased. So this increase means that there is still some amount of growth which is happening, and probably decrease in articulotrochanteric distance, which means that the probable explanation would be that there is a discrepancy in growth between the proximal femoral epiphysis and the trochanteric epiphysis. The trochanteric epiphysis keeps growing normally, whereas the proximal femoral epiphysis is arrested by the screw. So if you look at the mean increase in neck length, it was 8.6% from the time of screw fixation till skeletal maturity. Increase in the femoral offset was 9.6%. As we discussed, articulotrochanteric distance is the only parameter which decreased, and it was about 18.8%. So in our series, there was only one patient whom overgrew the physis. The screw was actually fell short of the physis. So the proximal femoral epiphysis kept growing normally in spite of the screw. So this is that girl who was actually prophylactic fixation was done when she was 11 years, and you can see that about in about 4 years follow-up, the femur is completely, the screw is completely short of the physis. The physis is growing normally, and this is the 10-year follow-up of the same thing. So fortunately, she did not develop any contralateral slip after 4 years. So whenever you see this, there is an indication to do an exchange screw fixation or add a second screw, particularly if you feel that the patient is a high-risk patient, if it is obese or endocrinopathy is there. So this patient was not in that category, so we just observed and he did fine. So moving on to discussion. So as we discussed in the introduction part, there are controversies and people have given definitive indications for prophylactic pinning, like younger age, lower modified Oxford risk score, and there is a posterior slope angle. There is an angle described, which is, and they say that if it is more than 12 degrees, there is an indication for prophylactic pinning. And one of the other markers is if your triradiate cartilage is closed, they say that the chance of developing a contralateral slip is very less. And that is again another one of the markers which we use for deciding prophylactic pinning. But there are surgeons, hip surgeons, who have started doing universal pinning for any patient with slip to avoid the risk of contralateral slip. And this was actually shown in the both European and American surveys, which was done in Pediatric Orthopaedic Society members, which a sizable number of surgeons said that they would do universal pinning. So that was our protocol. And if you don't do pinning, the problems are that you can develop a subsequent slip, and if it is not treated well, again it can lead to arthrosis. So if you do pinning, what are all the morphological changes you can have? You can have a short neck, your articulotrochanteric distance decreases. Rarely you can have chondrolization, AVN, which is more of a theoretical risk as far as I'm concerned. So if you look at previous papers which have looked into this morphological changes, we came across this one paper where they have studied 11 patients, and they also showed that there is a mean increase in neck length of 8.2%, similar to our paper. And they said that growth persistence is the rule after prophylactic fixation. So whenever you do a prophylactic fixation, does not mean that the growth completely stops. So it slows down and it holds the physis, and then eventually it fuses. This is yet another paper which was published in Journal of Hip Preservation Surgery, where they said that there is significant decrease in neck shaft angle. So we were surprised to look at this because in our series, the neck shaft angle was completely normal. There was no significant difference, even statistically. So, but when we looked at the data in detail in this, so they had 29 hips, out of which 18 were patients who had slip capital femoral epiphysis, and only 11 were prophylactic. So they included all 29 hips for this study, and that is probably the reason why they have had decrease in neck shaft angle in this series. So these were the only two papers which have properly looked at prophylactic pinning. So if you look at the strength of the study, this is one of the, we had a good number of patients whom we looked up at till skeletal maturity. And the problems are you have a wide age range. So as I told, we had a patient as young as 9 to as old as 16 years. And we did not study the clinical effect of this altered morphology, which is altogether different thing, which whether an altered morphology, decreased articulotrochanteric distance, clinically, whether it really matters. So that aspect is also not studied. So we concluded that prophylactic pinning does not stop the growth of proximal femur completely. And articulotrochanteric distance decreases, probably due to the discrepancy in the growth between the two physes. And clinical effects of this subtle change in morphology needs further investigation. Thank you. I'll be happy to answer questions.
This is a great paper, Venkat. And at one point,
I can't hear you, Maulin, properly. Hello.
Yeah, I'm on the way highway. So can you hear me now?
Yeah. Tell me.
So on one side, we say that prophylactic epiphysiodesis doesn't work well after, say, the age of 8 years or 9 years.
Yeah.
And in your study, we have seen that the AGD changes. So how do you explain that?
That's a good question. That's a good question, because we say that trochanteric epiphysiodesis does not work well in patients whom we want to correct the neck shaft angle, right? So where we have coxa valga and you want to correct the neck shaft angle, you want to prevent hip subluxation, that is the time when we say that trochanteric epiphysiodesis does not work if the child is like more than 8 or 10 years of age. probably the theoretically probable explanation would be that the apophysis still keeps growing, right?
Yeah, Venkat, all these change in the parameters was clinically problematic to the patient?
No, sir. No.
Okay.
So that is the beauty. So whenever we look at this short necks and high riding trochanter with decreased articular trochanteric distance, we presume that the patient will have a Trendelenburg sign, at least positive, delayed or stressed Trendelenburg. But none of these patients have any problem in the hip joint. So surprisingly, they all are very normal functionally. So, and again, so we do not know whether what will happen if we put a screw across an 8-year-old child or a 9-year-old child. That we need to really, because most of our patients are between 13 and 15, so which may not bring a lot of morphological change. So that is
So
something which we
Venkat,
really
one
avoid.
question. Sorry.
Yes, sir.
Venkat,
Yes,
one
sir.
question. Yeah.
Yes, sir.
I think you showed one patient at least where the screw had actually migrated distally.
Yes, sir.
I mean, the threads were no longer holding into the growth plate.
Yes, yes.
So did you see in this particular patient any changes in the morphological parameters, or I mean, what was the possible reason why it, I mean, sort of fell short of this? Was it like
that's
a
what.
poor
So
hold
we
of the
always say
screw,
that
or was
whether putting a screw actually stops the growth. Sometimes theoretically the set percentage is about when you violate 7% or more than 7% of the epiphysis, there is a chance of permanent growth arrest. So some of the patients, we have had 2 patients so far where I had to revise the screw where the proximal femur kept growing. So the patients were high-risk patients for contralateral slip. So I had to revise the screws. In one patient, I was not able to remove the screw. I had to do an add-on screw. So we have done that. So this particular patient, we did not do anything, and there was no change in morphology as such. If you can look at the proximal femur, it looks normal.
Thanks.
So,
But majority of patients, there is arrest of growth, there is short neck related to the compared to the opposite side, and there is decrease in articular trochanter.
Perhaps those are the cases where the screw has worked.
Yes.
In measuring the growth, and where the screw has perhaps not worked. So perhaps. Sir. Okay, thank you.
Hi, Dr. Venkatdass.
Venkat, if I ask.
Oh.
Yes, sir.
Yeah, Dr. Mosca, please go ahead.
Yeah,
Professor Mosca.
Sure. You didn't measure leg lengths, but by implication, if the trochanteric articular distance decreases by 5 millimeters, the leg length decreases by 5 millimeters. And that's not significant. The case you showed was a valgus hip to begin with. You actually made the trochanteric articular distance more normal by putting the screw across the growth plate. But that was just one example. So by not measuring leg lengths, which is not terribly accurate, I think the measurements you had were appropriate. By decreasing 5 millimeters on average, did you see a relationship between the decrease in trochanteric articular distance based on age? Your age ranges was 9 to 16. So did you see more of a decrease in trochanteric articular distance in the younger kids versus the older kids?
We did not do a subgroup analysis based on the ages because the number of patients in 9 to 12 was very less.
Okay.
So probably if we look up our data now, we'll be able to get more patients, and that's a great question and a suggestion. We'll look up the data again. Yeah.
And the important thing for everybody to know is that if you have a trochanteric articular distance of 0 millimeters, that the top of the trochanter and the center of head and the top of the head and the greater trochanter at the same level, people will limp 50% of the time. There's not a consistent Trendelenburg until the trochanter is higher than the femoral head. So there's a lot of wiggle room in there. And if you decrease 5 millimeters, even starting with a normal TAD, not a valgus hip like you showed, the chance of creating a Trendelenburg is extremely low. Extremely low. So again, that's not an argument not to do prophylactic pinning. And again, the reported risk of AVN and chondrolysis, you have to really be a bad surgeon to create AVN or chondrolysis. I mean, that's what the correlation there is, bad surgeon.
Yes, exactly. I completely agree with you.
Hi, Maulin. Hi, Maulin. Hi, Venkat. Jan.
Morning, Jayant.
Yeah, just to provide a counterpoint, I have never pinned prophylactically for about 20 years. Never had a problem. So this is for the non-syndromic ones, the non-metabolic ones. And I never had a problem. So I don't know.
You just need one patient to start doing prophylactic pinning in all patients.
Yeah.
You just have to see one patient who comes with an acute unstable contralateral slip. Then you will change your practice. That I changed my practice based on that. I had a bad experience and I never wanted to have it.
Agreed. So I will give you a point. So for 1 year, I started doing prophylactic pinning because all my juniors convinced me to do it. And then I developed a severe infection on the prophylactically pinned side. And it turned out to be a very rare fungus that only grows on trees. It's not even a human fungus. And it took us 3 months to make the diagnosis. And now that boy has a hip that I don't think I'll be able to salvage. The infection has settled down, but the hip is permanently damaged. So you only need one prophylactic pin to go the other way. And I've reverted back to my old practice of not doing prophylactic pinning. So what I'm saying is you can have all the evidence from the literature, but a lot of these decisions where the relative risk of you developing an adverse event is so low that it's very difficult to use evidence in such things to guide our practice.
What works for you works. I would argue on the other way also because I have been doing this for say 12 years now. 2012 we started, 2024 we are touchwood. I have not had any major problems in even a single hip of prophylactic pinning, except for one patient who had the drill bit breakage.
So the point I'm making is that is potentially a normal hip. And even if one small post-op complication happens, we'll be kicking ourselves.
I agree. I completely agree with you. That's what I made it a point in my presentation also, that you are operating on a normal hip and you should be extremely careful while doing a prophylactic pinning rather than doing a pinning on a slipped hip. So so that's two sides to a coin always.
Yes. Thank you.
I think, Joanne, we should move to the last paper because time is running. That's a valid point. Thank you.
Thank you. Bye.
Yeah,
Thank you, sir. Okay. Hitesh, sir, you can share your screen. We'll move on to our last paper.
Yeah. Good morning, everybody. My screen is visible?
Yes, sir.
Yeah. Good morning, Oscar, sir. Nice to see your comments, actually. Venkat, good to see your paper. We'll continue your points and we'll see about the greater trochanteric epiphyseal.
Thank you.
And I think the comment to your paper, the Maulin's question, why GT epiphyseal doesn't work. GT epiphyseal more than 8 years, pre-existing pathology or proximal growth arrest where there is a capital femoral epiphysis is abnormal, it doesn't work. Because like a Perthes or any other post-septic or post-DDH AVN, the greater trochanteric, because proximal growth would be abnormal. In that
what he said is actually the trochanteric epiphysis keeps growing. You are not able to fuse it. That is the reason the articular trochanteric distance decreases, right? So his question was like,
Yeah, correct. But then ATD, why we are not reversing in the disease condition, that doesn't work. So it doesn't mean the trochanteric doesn't grow. Trochanteric still grows up to 12 years.
Keeps growing, yes.
That's the reason, actually. The trochanteric is normal, proximal femur is also normal. So it will be benefited. What your conclusion is correct. That's what I'm saying.
Okay.
I'll quickly go through my paper because this is the international study group paper. It's not that my one. It's the many surgeons from the 24 surgeons from different part of mostly from United States of America and This is a study on the predictive of persistent limb following a proximal femur varus osteotomy for the Perthes disease. As we all know that varus osteotomy has become very popular for Perthes disease, and mainly because it retained the spasticity of femoral head. The results are excellent, and if it is done early means the first stage of disease. However, there are the issues with the varus osteotomy because the articular trochanteric distance will reduce and the limb may persist. There may be the abductor weakness and the shortening. These are the three main issues after the varus derotation osteotomy, and that is the reason initially the varus osteotomy was not popular. What happens is most of the study in Perthes follows on the radiological outcome, but no study evaluated the predictor of persistent limb following the varus derotation osteotomy. So the aim of the study was to determine the clinical, radiological, and surgical risk factor for the persistent limb after the varus derotation osteotomy in leg of Perthes disease. So this is a retrospective review of the prospectively collected database. This is the database for the 12 years. It started in 2012, and that's the 10 years collected data that has been evaluated. The inclusion criteria, we have included two databases between 6 to 8 year old and 8 to 11. So we included the patient with unilateral Perthes disease, bilateral Perthes disease has been excluded. And we have taken the children with only stage 1 presentation and stage 1 treatment. That means 1A and 1B. We excluded the patient with stage 2 because stage 2 that may be having collapse and fragmentation. So we may not analyze the same group. So we need to do about analysis. And what was evaluated, that's clinically the limb, whether it is present or not, that is yes and no. And if it is there, we evaluated whether it's a mild limb or a severe limb. We evaluated the age at the presentation and age at surgery, the BMI at 2 years and BMI at initially, whether the child is obese or not, and pain, whether the pain is before 3 months and 2 years. So all the data were taken, the clinical data were evaluated at presentation, 3 months and 2 years post-operatively. The radiological, we have evaluated the acetabular index, the C angle on the AP view, the neck shaft angle, and the articular trochanteric distance. Because all the X-rays from the various different centers, we don't know about the actual measurement. So it was all the JPEG image was converted into the DICOM image. So the ATD quartile has been done. What is that? The femoral head is divided into the 4 parts, 1, 2, 3, 4. The lowest part is 1, second, 3, 4, equal number of the division. And where the tip of the trochanter passes, whether it is in zone 1, zone 2, zone 3, or in zone 4. Normally, in a normal person, where there is when adult will be there, it is always there exactly in half. But in kids, because it's non-ossified, the trochanter, it will be either in zone 1 or in zone 2. So what happens at the preoperatively 3 months and 2 years after the surgery? We did the analysis, the univariate analysis and multivariate logistic regression to analyze the factor associated with mild and severe limp after 2 years. So he included the 95 patients, and out of 95, 50 has got the greater trochanteric epiphysiodesis while performing video, while 45 GT epiphysiodesis was not done. At the final follow-up at 2 years, the limp was present in 38 patients, means 40% of patients. The mild limp was there in 32%, and very severe limp was there in 8% of kids. When we evaluated the demographic and risk factors, if you see evaluated the age, the limb at presentation, the BMI, except the BMI, we see that BMI at 2 years of follow-up, none of the factors was significantly different between the limb present or absent. If you see that limb was not associated with anything except the children with having limb would be obese, that at 2 years of follow-up. when we analyze all the radiological factors, next after angle, C angle, articular-trochanteric distance, none of the variables, no radiological factors was associated with it. There was no association when we said the chi-square test and the parametric test. None of the factors was significantly present would be associated with Limp. Neither we initially thought that because of persistent varus or the amount of varus would be associated with the Limp. When we analysis about GT epiphysiodesis between the less than 8 years and more than 8 years, particularly less than 8 years, GT epiphysiodesis was protective. When GT epiphysiodesis was done, it was not associated with the Limp. When there is when GT epiphysiodesis is not done, we see the number of the patients on the Limp side was more. But same observation was not noted in more than 8-year-old age. So if we combine the both 8-year and more than 8-year, the entire cohort, the difference was significant. So that means GT epiphysiodesis was the protective for the Limp. And we see the difference between ATT, the quantitative measurement of ATT. Same observation was noted. Less than 8 years, it was protective, while the more than 8 years, it was not protective. So this is the first study to evaluate the predictors for the Limp, and the strength of study is a prospective multicentric study, and the surgery is done in early stage of this surgery, and this is evaluation at 2 years at follow-up. However, there are limitations because we have not defined the nature of Limp, whether it's because of what. Is it no 3D gait analysis was done? Etiology was not studied. What is the reason for the Limp? Prolonged non-weight bearing was also not studied. Ideally, all the patients should be followed till skeletal maturity, but this is interim data at 2 years. And no study of the technique of GT epiphysiodesis because 50 patients will various GT epiphysiodesis technique. However, we can conclude that for the 50% has got the Limp at 2 years and lower BMI and GT epiphysiodesis was protective. So we can explain the parents that there is a mild Limp is there at 2 years and GT epiphysiodesis is useful. How we can use in this paper into practice if we want to avoid the Limp at 2 years after the Perthes disease, always do the greater trochanteric epiphysiodesis in younger patient. Older patient also, it is not protective, but its ATD will be better. And as the child would be obese, it will be associated with the Limp. Thank you. Any question? We'll be happy to answer. Thank you.
Thank you, sir. So, Maulin sir has asked, how do you define mild and severe Limp?
Yeah, mild and severe Limp is before starting the study. We have already defined that mild is very subtle. Where it's obvious is very obvious in the that is we have defined already from the beginning before the database was constructed.
No, but Hitesh, the question is about like how do you define them?
Okay, so basically that we had the consensus for the definition of the Limp. You are saying that how would you define the Limp? Huh?
No, not the mild versus severe.
Okay, the first we have. Huh?
Yeah, Hitesh, please.
Yeah, so when there is the mild, severe Limp is defined as a very noticeable Limp, where the mild is there, the non-discretable, that's the very not noticeable, very mildly noticeable Limp. That was the actually original definition we have defined actually.
But how reliable it is? Like say this.
Yeah, that is also one of the biggest limitation. What you say mild, I will say it's severe. That is also
exactly. So interpersonal reliability or inter-observer reliability
not done. That is a limitation. That is definitely, but it's noticeable and not noticeable. That depends on the person to person and surgeon to surgeon.
And at the same time, some patients with severe limitation of physical rotations, they can compensate so well, and they would look that they don't have, or they would have very minimal Limp.
No. Limitation of the range of motion that cannot be compensated. We see if there is a limitation of range of motion, it will walk with the stiff hip or the short limb. When if there is a limitation of the range of motion, it would be associated with other problems, like either it will be having with the stiff hip gait or the short limb gait. So and it will be noticeable, at least mildly.
Yeah, so major drawback of this paper is the how to define a severe and a mild limb.
Yeah.
And as you said already, it's a subjective, finding. So if you conclude, Hitesh, children with higher BMI have a higher chances of having persistent limb.
Yeah. Yes. Yes.
And there is no and the severity of disease or the time of presentation doesn't is not significant.
That was not studied. That was not studied. Severity, we have not taken a type of fragmentation in stage 2. Similarly, it was not studied what is the amount of perfusion MRI. So this is all the patient is presented with the early stage of disease, not the late. The severity will affect. That is the reason it is a confounding factor. So that has been excluded initially for this particular paper.
Hitesh, I agree that that's a real so subjective. I mean that has to be one of the most subjective things in orthopedics. My question had to do more with the radiographs, as you and I and Dhiren found. It's hard to be reliable, although we found great reliability by teaching each other how to measure what we were trying to measure accurately, not to be unscientific, but actually to be scientific. So I would contend that it's very easy and reliable to draw the axis of the femoral shaft. I would contend that in kids in the first decade of life, it's very unreliable to draw the axis of the femoral neck. So if you're going to draw the neck shaft angle, what training did you do, or what inter and intra-observer reliabilities did you have to draw the neck shaft angle? So that's question number one. Why don't you answer that one? I'll get to number two.
Yeah, so what we have taken about the center of the shaft, that's easy, but it's when we have taken the ossified part of the head as well as the 3 points on the neck, and we have drawn the one line. That's how we have taken into neck shaft angle. And
did you each measure them twice? Did you do reliability? Okay.
Measured twice, and it was around 0.8, not 0.98 what we have measured in our CVT, but 0.82. So that was reasonably.
Okay. Not bad. My other point is that the greater trochanter ossification center is a small percentage of the ossification of the cartilage en log.
Yeah.
So that as children grow, the trochanteric articular distance decreases just with growth.
Yes.
Because the ossification increases within the en log.
Yeah.
So here you measured 2 years later. Well,
Yeah.
some of that decrease in trochanteric articular distance was due just to ossification of the greater trochanter.
Yeah, I do agree, because what we have done already varus, so the zone 1 I have put into zone 3, but after the trochanteric epiphysiodesis has it been effective, zone 3 we can get it from zone 2, that is means GT is effective. But because of varus, it is already gone high.
Okay.
Yeah, so that is, and what your question is absolutely valid, because when we studied about GT epiphysiodesis paper 18 years back, we have studied on the normal side. What we have seen also, the observation is absolutely correct. As it's ossified, it's getting less on that.
Yeah. Great.
So if there is no further question, we are at 9 a.m. and we could finish all these 3 papers well in time. I thank all the authors for sparing time, and I also thank Dr. Muska for your lovely input. Thanks, Joanne, for moderating this session. And we shall meet next week with us.
Okay. Have a good day. Bye.
Thank you, sir. We'll conclude the session now.